Hello everyone, welcome to Hot Seat. I'm Omid Moghaddas from Tehran, and I'm so grateful to be with you all from this educational platform once again. And today, I'm very excited again to have a wonderful educational teacher, a mentor from Paris, France with us, Andre Saadoun. Welcome, Andre, to Hot Seat.
Thank you very much for your kind invitation, my dear friend.
It's an honor for us to have you on Hot Seat, and I'm pretty sure all of the audience are excited to hear your presentation. Andre gonna talk about aesthetic smile and crown lengthening procedures today, from conventional approach to digital approach, which I believe is very important for all of us to know the details about it. And digital dentistry is a hot topic today, and on Hot Seat, it's great to have crown lengthening from the digital aspect and know about its details. So as a tradition, I will have Professor Andre Saadoun's CV for all of you, and then we go to the presentation directly. Dr. Saadoun has received his degree in dental surgery from the Faculty of Paris and completed his postgraduate certificate in periodontology at University of Pennsylvania and postgraduate certificate in implantology at University of California, Los Angeles. He was an associate professor in the Department of Periodontics at the University of Southern California. He is also a visiting professor at Hadassah Jerusalem University. He's a diplomate of American Academy of Perio, diplomate of ICOI, member of honor of American Dental Implant Association, and president of the Rencontres Mediterraneans of Dentists. He has received the French Medal of Chevalier National de Mérite. I don't know if I pronounced it right. He's an internationally renowned...
Yeah, Chevalier de l'Ordre du Mérite. Yes.
Yeah. He's an internationally renowned lecturer in perio and implant. Dr. Saadoun has written over 150 articles and several book chapters. He's a contributor in the book entitled The Art of a Smile, The Art of Treatment Planning, and associate editor of the book Implant Site Development by Quintessence. He is also on the editorial board of scientific journals, so many of them, and a faculty member of the Global Institute of Dental Education in Los Angeles and faculty member of Dental XP Program of Education in Atlanta. Dr. Saadoun maintains a private practice in Paris, which is limited to aesthetic periodontics and implant surgery. And I had a chance to be Dr. Saadoun's host in Iran 2 times, hopefully make it for the 3rd one in the future. And we had the biggest hands-on workshop and animal models with Dr. Saadoun in Iran on soft tissue surgery,
yes,
lab management.
I do remember.
Yeah, and it was an amazing event. And the way that Dr. Saadoun describes, he's like truly a teacher. He goes step by steps in every details, and I think all the participants feeling very lucky to be in his educational workshops. So, Jay, we are super excited to have you again, and we are ready for your amazing presentation.
Thank you, my dear Omid. It is a pleasure to accept to be part of the Hot Seat meeting that you're organizing. This is the period of time of the COVID-19. By the way, maybe in the CV, we do not tell us about the book that I have published on the soft tissue management around teeth and implant, which was the first book dealing with the 2 topics in the same time. And as you know, it has been translated in 6 languages. Hopefully it will be in Persian and Brazilian. Now, the topic I'm going to present, in a way, it's a very old topic, but is it an easy one? I would say no, it is not an easy one. we can think about the conventional way, which is also more difficult than today, the digital one that we can use today for the digital workflow, make the thing easier because we prepare everything in advance. But still, this is a very demanding procedure, and people should be aware of many backup and many hassles that they could find during their work. Therefore, it will be very important for me to define on the first long introduction of this lecture, the periodontal parameters, which are going to give you the light, how to look at your patient, how to define the many parameters, and how to define, first of all, the diagnosis, and then the classification. From these two important points, then you will be able really to manage any case. So this part of part 1 hour will be the part one. Then there will be a second part dealing with what we call the class 2, where you have the bone at the CEJ. But let's start with the first part, with all these periodontal parameters, which are very important for me. And please take the time to follow attentively each part of it that you will find after during the surgery, okay? I do thank you very much for listening and for asking questions at the end if you want. Thank you. It is my pleasure to give this short lecture, about 1 hour, I suppose, to the Global Summit. And I hope that we'll have more opportunity to meet and all together after this COVID-19 over the world. We'll be speaking about the general smile and the crown lengthening procedure from conventional to digital approach. The mouth is the expression of our health. In other words, we can see in the mouth many signs if we're in a good health or in bad health. We know that there is a link between periodontal disease and general health. There is some link between cardiovasculars and periodontal disease and all these different comorbidity. And by the way, I just received this morning an article about the coronavirus saying that in fact, it is another bacteria that we know very well as a periodontist, the Prevotella, which is invaded by the virus, and it is the reaction of the virus inside the Prevotella which induce all this problem that we have today. And if I look carefully on this picture with all this disease that people can have, like cardiovascular disease, diabetic, obesity, digestive cancer, AVC, this is exactly all the signs that the physician are telling us with the patient they have reanimation and death. In other words, it seems to have a reaction between this Prevotella bacteria, the COVID virus, which is going to invade this bacteria, which go in the intestine and give diarrhea, for example, and then very inflammatory reaction. And we find a kind of correlation between all these comorbidity disease and the COVID-19. In other words, these bacteria that we find always in periodontal defect with periodontal disease, aggressive or chronic, is part of this co-infection between the COVID-19 and these bacteria. We'll see. This article from Chinese and American and English and French. We'll see if it is right or not. It is one way, maybe. Any attempt today of restorative therapy in the absence of periodontal health is doomed to eventual failure. This is a law that we learned in 1980 when I was at Penn University. Periodontal health is the key for the long-term success in dental and implant work. Without this, we'll have a lot of problem and complication. It is necessary also not only to remove periodontal disease by scaling root planing and periodontal treatment if necessary after re-evaluation, but also to know how to work with a team approach between the dentist, the specialist, and the laboratory artist or technician, if you want. There is a correlation between the aesthetic of the face and the aesthetic of the smile. In fact, it is necessary before any type of surgery that you will do, any treatment that you will do, to make an aesthetic global evaluation on the face, on the dental labial parameters, and the buccal parameters. The smile is one of the most important elements of the face, and even though the lower third of the face is just 30%, when you smile, the proportion arrive to 48% of the beauty of the face, which means how important is this smile, especially when it is very harmonious. The smile should respond not only to aesthetic norms, but criteria. But if you are going to restore the smile, it has to be done in harmony with the facial aesthetic. If we look to the facial analysis, we look primarily to the medial line to see if there is some symmetry or asymmetry or disharmony, the bipupillary line, the dental lips line, the face proportion, the disharmony, the nasolabial angle when you see at the profile, and the face in motion. Then, if we look at the dental labial analysis, we can ask the patient to just close the lips, then slowly start to speak and smile. This is what we call the different smile of the smile in motion. Then we go to the buccal analysis. We know that women have longer teeth than men, for example. We will see what will be the position of the lips, what will be the shape of the teeth, the shape of the smile. But the smile changes with the civilization, the society, the age of the patient, the diet, and many other parameters. To smile or not to smile, this is a question that very often we have in our clinic when we ask the patient to do it because we want to take some picture. Some, like this one, is not reluctant to do it because she has beautiful teeth, beautiful smile. The other one is more reluctant to do it because she does have diastema, teeth are missing, crooked teeth, I would say, and irregular position of these teeth. Therefore, it is necessary to know very well the biologic parameters before starting to work on the patient. We want to know exactly which is normal, which is abnormal, and make a diagnosis, and from the diagnosis, we'll make the treatment, the only treatment which corresponds to the diagnosis. If we consider the lip line, for example, the upper lip line, it is the position of the lip, of the upper lip, when the patient speak or smile, and depending on the degree of exposition and contraction of this muscle of the upper lip, then we have variation on the smile and variation on the teeth and gingival exposure in each individual situation. The smile is a combination of the lips, the teeth, and the gingiva. Therefore, we should know that the lip proportion are respecting the golden rule. The upper lip is less important than the lower lip, and you can see the number. This is why when you do injection on the lips, it is very important to respect this proportion and not to make an upper lips larger and more fluffy than the lower lip, because it will be in disharmony with the face. Depending on the level of the upper lips, when you smile, you can have the high lip line on 10% of the patient, the medium lip line, 70% of the patient, and the low lip line on 20% of the patient. You can see, depending on the position of the lip, that you are able to see more or less teeth and gingiva. There are, in fact, multifactorial etiology of the gingival smile. The first one is the osseous etiology on the basal bone or the alveolar bone, and sometimes combination of the two. Muscular etiology, we may have hypertonicity of the upper lips, or we can have also a shorter upper lip. Then the third point of the etiology is the dental etiology. We may have shorter teeth with a lot of keratinized gingiva, or we may have what we call altered passive eruption, when you can see on the last picture. The gingival smile can result from this different abnormality and is often a combination of the several one, okay? Therefore, this gingival smile is a multifactorial origin, and it cannot be successfully treated in depth if aesthetic and etiological diagnosis has been defined. This is very important. We have to know which is the etiology of the gingival smile on the patient which is on the chair. Therefore, we have to do all the analysis necessary to define this. Garber and Salama have written an article in 2006, and they have done one classification of the vertical aspects based on the height of the exposed gingiva. The degree 1, when you have 2 to 4 millimeters of exposed gingiva, this is the picture that you have, degree 1. Degree 2, you have between 4 and 8 millimeters of exposed gingiva. Degree 3, you have more than 8 millimeters of exposed gingiva. Are we going to treat all these gingival smile the same way? Certainly not. You can see all the different treatment that we can give to the patient depending on the degree. And the more the degree is important, like degree 3, the more we are going to be more invasive with, for example, an orthodontic surgery with or without periodontal surgery and restorative treatment. And if we go to degree 1, then we can do only orthodontics, add some Botox maybe, and acid hyaluronic, and do periodontal surgery and or restorative treatment. We will focus only on the degree 1 for this lecture. In other words, when the gingiva is between 2 and 4 millimeters, showing when the patient is smiling. It is, as I said, very important to know the different parameters. We have seen the lip. Now let's speak about the gingiva. The gingiva, the frame could be in harmony or in disharmony, depending if we have or not gingival recession or abnormality of the position of the teeth. The color could be pink on the white people, I would say, and pigmented on the black people. The texture could be normal or could be inflamed because of periodontal disease or in general. Now, it is also important to know that the thickness of the tissue are very important, especially in the treatment we are going to give to our patient. We have two types, the thin and the thick. The thin is usually scalloped with festooning, height and rising of the gingiva, long papilla, or we have the thick, which show a flat contour and a large amount of keratinized gingiva. There is a prerequisite, there are prerequisites to achieve a long-lasting soft tissue health and aesthetic around teeth and around implants, certainly. The height and the thickness should be always as a prerequisite of 3 millimeters. That would be the minimum to maintain the health and aesthetic of our patient. Smile. In whatever treatment plan we are going to do and give to our patient. The bone is also a very important factor, especially when we do crown lengthening, because most of the time we'll be obliged to work on the bone, to raise the flap, expose the bone and work on the bone, restore the bone to a certain level. The density, the quantity, thickness and height, topography mesiodistally and buccolingually, the defect, are they horizontal or vertical? And the teeth relation. Is the tooth in the correct position inside the alveolar socket, or is it in malposition? And in that case, we can have some dehiscence, fenestration, etc. But in general, the buccal crestal bone should follow the gingival margin. That's a rule that we know for many, many years. And we try, when we do osteosurgery, to restore this parallelism between the bone level and the soft tissue level. Normally, this level is about at 3 millimeters, okay? And we will see why later. If we go deeper in the definition of the thickness, we can find that Wilson in 1980 and Levenginsius in 2009, that we have many types of thickness and many types of thinness. The very thick biotype, the bone is thick and the gingiva is thick. On the very thin, the bone is thin and the gingiva is very thin. In the middle, we may have thicker bone and thin gingiva, and thinner bone and thicker gingiva. These are the medium biotype, I would say. It is important for us to determine, especially today with a CT scan, to what type of biotype we are dealing with. This is very important for the analysis and for the treatment indirectly. The teeth are different between the patient. They could be triangular, ovoid, or square, and it is related with the biotype. We'll see that in a few seconds. Are they in a good or malposition? What is the length and the width of this teeth to give us the ratio, the proportion that we like to have about 80% between the width and the length? Is the bone relation of the teeth is adequate or inadequate? Where is the contact point? Is it more apical, like it is on the thick biotype, or is it more coronal, like it is with a thin biotype? And the last point is definitely the shade, the value, the hue, the chroma, the texture. This is more for prosthodontists than periodontal specialists. As I said, the teeth are in relation with the biotype. Usually triangular teeth are in relation with thin biotype. The square teeth type are with a thick biotype. And in the middle, you have ovoid incisor, for example, on the medium biotype. Therefore, you cannot mismatch all these parameters when you do the surgery. You have to be respectful of your base. What type of biotap are you working with? What type of teeth are you working with? And indirectly, what type of bone subjacent to the gingiva are you working with? And you have to restore exactly the same shape following the CEJ, which will be the key parameters to redesign perfectly the contour of the bone and the gingiva in order to obtain and respect the type of the patient. There are also some outside reference on the teeth and the gingiva. The one in the middle, the gingival contour and the interproximal point, you can see that it is the length in the contact point, in the surface of the, which are giving the length of the papilla. There is a kind of perspective of the smile with the higher on the canine and the central and slowly decreasing toward the posterior teeth. This perspective also is given by the zenith of the teeth, which is distally on the central and canine, and it is in the middle for the lateral. And the gingival contour follow this design of the zenith, but with the lateral, it is always lower by 1 to 1.5 millimeter compared to the line joining the central and the canine. These are very important parameters that we have to follow and restore by the surgery in order to have an aesthetic, beautiful result. The interpapilla is defined by the interproximal bone height and the cinemo-omental junction. It is defined also by the interproximal bone crest and the interdental contact point, or the distance between the teeth. The more bone you have interproximally, the more this bone will be vascularized. When you have less than 1.5, then this alveolar bone is jeopardized. Therefore, it is good to look at the retroalveolar X-ray to see what is the distance between the two CEJ on the proximal area. If we go back to the lateral view, then you know, according to the Turner law, that the distance from the contact point to the crestal bone should be between 4.5 and 5 in order to have the full papilla. And as soon as you remove 1 millimeter, then you decrease this distance, this possibility. You increase this distance, but you decrease the possibility to regenerate this papilla. And definitely when you have a distance of more than 5 millimeter between the CJ and the contact point, the bonosis is poor, and that means you have about 8 millimeter from the contact point to the crest of the bone, and you lose the papilla. Therefore, our objective is to restore this distance between the CJ and the bone when you do the crown lengthening in order to obtain full papilla at the end of the healing and maintain. We know also that the height of the papilla decrease from the central to the posterior areas, from the central to the molar. Why? Because the length of the surface of contact is going to decrease from the central incisor to the molar. Therefore, when you do the bone recontouring, you have to redevelop a kind of triangle interproximally on the central, lateral, central, first premolar, and slowly, slowly, the surface, instead of being vertical, become horizontal. Therefore, the height of the papilla decrease, and it is very logical not to do the crown lengthening and the bone recontouring on the anterior teeth as it is on the posterior teeth. If not, you're going to have a disharmony and ugly result. So everything comes from these parameters. This is why I'm spending some time on this long introduction. PASCAL Mind has defined the aesthetic reference for the smile. In red, you can see what we call the pink aesthetic score, and in white, the white aesthetic score. I let you read this carefully in order to remember that you, as a periodontist, should be very careful with the pink aesthetic score. The restorative should respect what you have done and should restore at the best the teeth by laminate veneer, by crown, by etc. This is very important. It has to be a perfect coordination between the work of the periodontist and the work of the clinician for the restorative work, in order to have a high aesthetic score with the pink and with the white. One parameter is the key factor. It is the tooth biological space. In fact, it is the volume of length and width. The one on the middle, the picture on the middle, show exactly that the normal biologic width without inflammation or with inflammation is always 2 millimeters. The sulcus depth vary. Healthy, you have about 1 millimeter, and inflamed, you have much more because the gingiva is inflamed and is higher in size. Therefore, if you have this perfect, healthy component at this stage, if you decide to do a supragingival preparation, you have to give to your restorative dentist about 3.5 to 4 millimeter of teeth structure in order to do a supragingival preparation. If on the reverse, you do a subgingival restoration or you do a preparation, then you have to give to your dentist about 2.5 millimeter to 3 millimeter, depending on the sulcus depth, for your dentist to be able to do a subgingival preparation without violating the biologic width. Because if you do that, you may have a recession on a thin biotype and inflammation on the thick biotype. Therefore, the biologic space should be always respected. It is important to do the preparation with loupes in order, or microscope, to see exactly to what level you are in the sulcus, in order not to touch the gingiva, in order not to violate the biologic width. Coming close to the surgery, it is, as I said, also important to know what is the amount of keratinized gingiva that you have before you reach the mucogingival junction. So you have the free gingival margin, then below you have the biologic width and the bone crest. Then you have a certain amount of keratinized gingiva or attached gingiva. It is attached on the connective tissue, but not on the junction epithelium, and on the sulcus. Therefore, this reference should be also taken in consideration when you do your examination, your diagnosis, and your treatment. You want to achieve surgically the correct positive bone level architecture by resecting the precise amount of available bone and restoring the adequate supracrustal tooth structure to respect the biologic width. This is very important. But you should know also that all this type of work, which is very demanding, very precise, which also is in taking in consideration all these biological and scientific parameters, should be destroyed if the oral hygiene is not respected and maintained, if you have a missing precision fit, if you have bacteria from the Bargic film, which is going to increase vascular inflammation and jeopardize the aesthetic. And you can see on the two pictures here that definitely we have inserted a beautiful laminate veneer done by my friend, Dr. Nazaré Michalchuk. And then after a few weeks, if the patient is not brushing, then you are in problem. The aspect will be different, the tissue will be inflamed, and the aesthetic will be lost. So as I said, we are going to take care only of the degree 1, where the gingival exposure is between 2 and 4 millimeter. And you will see how we are going to treat this gingival smile on a degree 1. So I define that like gingival smile, diagnosis, classification in degree 1. We had already one classification done by Garber and Salama. Now we are going to see something different. This is exactly what we call a gingival smile. You can see the amount of keratinized gingiva, which is hiding part of the crowns, make the crown look much shorter. It is important to know what is behind this gingival, keratinized gingiva. Where is my length of my teeth? Where are the CJ? Where is the bone crest? Where is the mucogingival junction exactly? How much keratinized gingiva and attached keratinized gingiva do we have? We have to establish a diagnosis before any clinical crown lengthening procedure. So we can take an X-ray, retroalveolar X-ray. Today, I will use the CBCT, which will give us more information. We can take the probe and measure the depth of the sulcus. We can use the U3D gouge to see the teeth proportion, and that gives you the exact amount of the tissue that you have to remove. And maybe if you have bone below, the same amount of bone should be removed, which is not always the rule. And you can also, under local anesthesia, find out where is the bone level by doing a bone sounding. All these tools are able to give you part of the diagnosis, I would say. It is important now to go back a long time ago, 1977, in Philadelphia with Professor Koslet and Weisgold, Rosenberg, Cohen, and Morton Amsterdam. They have defined two types of gingival smile. One based on the distance between the CJ and the mucogingival junction. In other words, what is the amount of attached keratinized gingiva? So if the MGJ is far away from the buccal crest of bone, then from the CJ, I would say, then you have plenty of keratinized gingiva. If it is close, then you have a limited keratinized gingiva. You have now a subtype, depending of what is the distance between the bone crest and the CJ. If this distance is between 1.5 and 2, this is type A, which is the majority of the patient. If, unfortunately, this distance between the CJ and bone crest is less than 1 millimeter, 0 to 1, I would say, then we are dealing with another type of gingival smile that we called altered passive eruption. So we have two types now. The type A is a natural passive eruption. The teeth are erupting normally with the wear during the age. There is a kind of passive eruption, but everything moves together. When, on the contrary, on an altered passive eruption, you have a kind of ankylosis of the bone and the CJ, and the gingiva is just growing there, and the biologic width is above the bone. So we have two types, one type 1, type 2, and two subtypes. The A, when you have plenty of keratinized gingiva, and the type B, when you have the CJ close to the bone. Okay, so let's go now to a kind of resume of this, and then we will start soon the crown lengthening. If you look at this picture here, the type A, you can see you have a large band of keratinized gingiva because the distance from the gingival margin to the mucogingival line is important. And the distance between the CJ and the bone crest is 1.5, a normal relation. The type 2A means that we have a limited band of keratinized gingiva. In other words, the mucogingival line is close from the CJ. And we have to be careful about this amount of keratinized gingiva. If I make a cut and I remove all the gingiva, then I am in bad situation. So type 1A, a large amount of keratinized gingiva. Type 2A, minimal amount of keratinized gingiva, but the same relation between the CJ and the bone crest. Going today to the CT scan, we can see easily where is the thickness, where is the bone level compared to the CJ. And this is an example where you can see that we have between 1.5 and 2 millimeters of distance between the CJ of the tooth and the bone crest. You can see also the thickness of the bone. You can see other detail, the length of the teeth, the position of the teeth, etc., etc. So this CT scan has given us a lot of new information that we didn't have 10 years ago. The type A, you have, again, large amount of keratinized tissue, and the type 2A, you have limited amount of keratinized gingiva, but the situation is the same about the CJ and the bone crest. If you go to the altered or delayed passive eruption, then it is a different story. You can have the same picture for the amount of keratinized gingiva, more or less, but this time there is almost no distance between the CJ and the bone crest. Therefore, we have a type 1B, huge amount of keratinized gingiva is a minimum distance between the CJ and the bone crest. Type 2B, minimum keratinized gingiva and minimum distance between the CJ and the bone crest. Looking to the CT scan, then you can see that in this kind of case, the bone is thicker. The distance between the CJ and the bone crest is very limited, non-existent sometimes. And we call this case altered passive eruption. Therefore, we are going to treat this case totally differently when I see this altered passive eruption. Type 2B, huge amount of keratinized gingiva, thick bone, CJ at the bone level. Even the radiographic X-ray, the retroalveolar, is showing you that the bone is at the CJ. So we have the perfect diagnosis of type 2B. All this science is based on a lot of work, a lot of publication, a lot of book reading. This is some of mine that I have published along the year, talking about this problem and other problems, teeth and implant, always about aesthetic always. And recently, a few months ago, was published this beautiful book in Brazilian, Gingival Smile, by my friend Sergio Khan and Alexandre Tavares, Multidisciplinary Vision in 2019. Is a beautiful atlas that I recommend also. So let's speak about the crown lengthening, the core of the topic of my lecture. The purpose of this is to move apically the biological width. These techniques are multiple and depend on the initial situation and what you are looking for at the end. This final objective could be aesthetic by the demand of the patient, saying when I smile, I show too much gingiva. Biologically, there are some broken teeth, for example, and the biological width is not allowing us to take an impression, for example. Biomechanically, we have to increase the tooth structure to be able to do the preparation. These are the main objectives of this crown lengthening procedure. And we have to restore at the end the aesthetic of the smile. So important objective, you have to think about it. If you think about all the periosurgery, you divide it in two. We are working on the crown length procedure. On the other side, we have the gingival recession. On the crown lengthening procedure, we can have some with osseous recession, some without. Let's speak about without recession, osseous recession first. Some people may ask, but what about gingivectomy, gingivoplasty? Yes, it is one type of treatment, but it is very invasive. It's not tell me I cannot touch the bone there. We have an open wound. It has today very limited indication, and I will not recommend at all this surgery to do crown lengthening because you don't know exactly where you go and what will be the result. Even though we may have, when you have experience, excellent result before and after. So let's see the conventional crown lengthening on gingival smile on a type 1A. So you have a large band of keratinized gingiva here, as we define, and the distance 1.5 to 2 between the CJ and the marginal bone crest, and you may have more than 6 millimeters between the gingival margin and the mucogingival junction. So a huge amount of keratinized gingiva. This one case, an old case, when the patient was only speaking, you can see the gingiva. She was tall, but she has very short teeth. And that was her complaint. She was a model. She was not able at all to smile, make portrait, smiling. She was always closing her lips, which is not very convenient for her job. If we look carefully, we have a disproportion between the teeth. We have more than 7 millimeters between the gingival margin and the buccal crest. You can see. Huge amount of keratinization before we reach the mucogingival junction, excess of gingiva. So it is important to remember that we need to have at the end of each surgery, one way or another, by resection of tissue, by resection of bone, we need to have about 3 millimeters between the new level of gingival margin to the new level of bone. In this case, if we have 7 millimeters, and when I make my cut at 4, in total acceptance and agreement of the patient of the level of the new smile, then I know I will have a remaining 3 millimeter between the new bone crest and the gingival margin. I mean, the new gingival margin and the bone crest. This is important to understand. The first cut should be done always with the agreement of the patient. The digital smile design will allow you, maybe, certainly today, to define in agreement with the patient what should be the level and the height and the length of the teeth and the teeth proportion. Then you do your incision. But I told you it's an old case. We didn't have the digital dental smile at that time. And we were just working on the retroalveolar X-rays, bone sounding, bone probing, measuring the amount of keratinized gingiva. Therefore, if here I remove 4 millimeter, then, and I do the surgery on the uppers and the lowers, then we do the full mouth suturing technique, continuous suturing technique. We know that remain between the gingival margin and the crest of bone that I did not touch in that case, 3 millimeter, which will give me the amount necessary for creating a new biological width and a new sulcus of 1 millimeter. This tissue heals very well and very fast because the thickness is important. You can see after 3 months that now our patient is totally satisfied and there is nothing to do. The biological width is restored to a different level more apically, and nothing will move if our patient, which had been, by the way, well instructed by our hygiene, like all our patients before we do any surgery, this is a very important statement, nothing will move. And we will see this patient, I would say, every 4 to 6 months for regular maintenance. Let's see a case with osseoresection this time. It is necessary to remove the bone or to touch the bone. We do still have the type A, 1A, with a large band of keratinized gingiva, a good relation between the CJ and the margin bone crest. And we do have here, by the way, 3 millimeter between the gingival margin and the mucogingival bone crest, mucobuccal crest. So this is exactly where we have definitely to apically reposition this 3 millimeter, which contain, as I said before, the biological width and the sulcus, more apically. And then now you can understand that in order to apically represent this tissue, we have to touch the bone. This is why we're going to do some osseoresective surgery. Give you an example. In this case, the gingival margin to the buccal crest, when I do the bone sounding, is 4.5 millimeter. In other words, I have excess of tissue before I reach the bone. If I remove with my cut, with agreement of this level with my patient, then remain 1.5 millimeter between the new gingival crest, the new gingival margin, and the old bone crest, 1.5. Therefore, I have to remove about 2 millimeter. I have to remove 2 millimeter, 1.5 millimeter to 2 of bone to, after apically repositioning the flap, have the distance of 3 millimeter between the bone crest and the gingival margin, sulcus and biological width. So it's mathematic. You remove X millimeter, you have to remove X millimeter of bone. Okay? This before initial consultation, the same patient done by Dr. Duval with laminate veneer. Nice contour, nice work. We see normal gingiva like we saw in 70% of the case where you see only the papilla. Another crown lengthening, type 1A with osseous resection, but this time we try to be less invasive. We don't have to raise the flap because we know what we are doing. We know today with some instrument that we can work below the flap, like doing some tunnel for mucogingival recession, for example. So this is a young patient, reluctant to smile. As I said before, he was not happy with the smile. And when he finally smiled, you can see that the teeth, lateral and central, are very short. The good level, I would say, are the canine. And maybe this level will satisfy the patient. So we can discuss with him. Showing the probe, making a design with a pencil, for example. If I do that, would you be willing to accept my incision there? Yes, fine. Now we take picture inside the mouth and you can see the amount of keratinized gingiva, which is very thick, very important in length. And you have some very short papilla, which is not very aesthetic, by the way. You may have also some lateral diastema between the central and the lateral on the right side of the patient. So we did have, as we do all the time, a questionnaire of the patient to see if they are in good health, if they are taking any medication. This patient forget to tell us that he has taken aspirin a few days ago. Therefore, when I did my surgery, I'm going to have some surprise. When I do the bone sounding, the probing and the bone sounding, I can see I have about let's say 2.8, 2.7 millimeter before I reach the bone, before I reach the 3 millimeter of odontogingival restorative interface. See what we are going to put our preparation for the teeth, for the restoration. As I said, because he was taking aspirin, as soon as we start cutting and removing 3 millimeter, we were having some blood. Therefore, we finished to do this incision. Then we had to put the suture, put some gas for 5 or 10 minutes to stop the bleeding. Then we reevaluate with the probe the position at the margin of the tissue, and then by sounding the tissue here. Margin here, 3 millimeter. Then we push the probe to find the 3 millimeter. So this 3 millimeter did not come like that. I had to take a burr or a laser, like was described by Coyce 10 years ago. Or you can take today a piezo instrument to restore the normal depth of 3 millimeter of the dentogingival restorative interface. In other words, this 3 millimeter of biologic width plus sulcus. This is done without raising the flap. This is done by staying against the bone, against the root. Maybe you may be touching the root, but it is not dangerous at all because this root is going to be covered by the gingiva. It is like we do mucogingival surgery to cover a gingival recession. We do touch the root. We do grind the root to make it flat, to make it concave sometimes. Okay, so we have a very small burr of 1 millimeter, and we are going to just contour the bone without going to the proximal area. We want to keep this interproximal bone there. We don't want to lose our papilla. Then we finish with a burr of 3 millimeter here of length to be sure that definitely we do have our 3 millimeter of odontogingival restorative interface. End of the surgery, we put some humid gas on the surgical site for 30 minutes. Then we dismiss the patient. We never dismiss the patient if the patient is still bleeding. Okay, this is very important. Ask the patient not to take aspirin anymore for this time. It was the flu, so he was taking aspirin. And look at the healing. 3 months later, you can see the central at the level of the canine. We have let's say the zenith of the central on the distal of these teeth, and the lateral are shorter than the line joining the canine and the central. New smile of the patient, very satisfied, always smiling now. He has no reason to refuse to smile. This is very important because our satisfaction is coming for the patient telling us, thank you, doc, you have done the good work. I like it. I can smile now. Today, we are in digital world, and we are going to adapt our work to the digital workflow in a way. With the CT scan, with a digital machine and all that, we are able to design with precision where should be done the cut for the gingiva, where should be kept the cut for the bone, and we create what we call a double digital surgical guide. This is the case. We are now in type 1A. We have a lot of keratinized gingiva, gingival smile, and you can see on the other picture this digital double surgical guide with precise gingival contour and adequate bone level. The design of this contour are giving you the new level of the gingiva and the new level of the bone. Okay, so let's see how we are going to manage this case. Much more easy. Let's say that the work is done in advance through the digital workflow. We are going to design with precision now, very easily, not having to take any measurement again, because we know from the CT scan that we have 1.5 to 2 millimeter between the CJ and the bone crest. And the first incision is going to be an internal bevel marginal incision. Then it will be combined with a circular incision in order to detach, to remove this piece of margin of tissue. Then we raise the full thickness flap, in order to grind the bone to the new bone contour. This is before. You can see that the bone is not at the CJ. There is a kind of disharmony of the bone level. We have thick bone, and by taking the burr, we high speed level and a lot of water. It is important to slowly remove the thickness, decrease the level of the bone in order to obtain a beautiful aesthetic bone positive architecture. This guide could be put and removed after taking some reference in order to show exactly if you are doing correctly the job. It is elegant. You can see that the central are higher than the lateral on both sides. The canine are at about the level of the central. So we are in a good shape. And starting from the canine, we decrease posteriorly the height of the bone level in order to have this kind of perspective. Then we do reposition, I would say, the gingival flap exactly at the same level minus the amount of tissue we have removed, okay? But we know, because we did it with a surgical guide, that the distance between, I come back, the distance here between here and here is 3 millimeters. Always, always, always. Okay? So when you finish the surgery, you know that you have your 3 millimeter. You know that you have your biologic width plus the future sulcus. Now we go to the conventional crown lengthening on the gingival smile, but the type 2. In other words, we have limited of keratinized gingiva, but the relation between the CJ and the bone is the same, 1.5 millimeter. And we are going to use our hands and measurement. Okay, I repeat what we saw before. Type 2, limited band of keratinized gingiva, and normal relation between the CJ and the marginal bone crest. This is a patient with a limited amount of keratinized gingiva. He's not very happy with the appearance of the teeth, the shape of the teeth, and he wants to have some laminate veneer. Therefore, it was decided with the restorative dentist who referred the patient to me that we had to do some crown lengthening from canine to canine to restore the contour and build up something more aesthetic. We are raising the tissue. By the way, this is now a circular incision. The fact that we have limited amount of keratinized gingiva, we have to be very mini invasive here. We don't want to cut any marginal tissue. We want to keep these 2 or 3 marginal tissue that we have. It is so precious. I don't want to remove 1 millimeter. Okay, now the bone, you can see it's irregular, not exactly parallel to the CJ, don't have any peak of bone interproximally. Therefore, it is important to do a bone resection of 1.5 millimeter to create a positive architecture, to have the peak of bone interproximal to be higher than the bone on the buccal. I have a nice positive architecture. Interrupted suspended suture with an apically repositioned flap. So before we do the suture, we'd have done a partial thickness flap to be able to move the tissue more apically. And now you can see after 1 week, the tissue exactly still at the same position. And the contour now is more elegant than it was before. Especially we have an ulceration on the canine that we can treat after by some tunneling and some connective tissue graft. At this stage, few weeks, few months later, the patient can go to see the restorative dentist and have the laminate veneer. 3-month healing, it is time for him to go. And you can see the difference between the initial consultation, where the teeth were not rectangular for the thin biotype, when it should be, and the tissue, how healthy they are, how the papilla are going to come, or if they don't come after the surgery, 3 months of healing or 6 months of healing. With a laminate veneer making the teeth much larger, we are able to recreate a new contact point, which will regenerate, in a way, the peak of the papilla. Now let's see the digital crown lengthening on the gingival smile, type 2, this time, minimum keratinized gingiva, using the digital surgical guide. To repeat, because teaching is learning, and learning is repeating the thing. The type 2, I remind you, limited amount of keratoid gingiva, less than 3 millimeter. The same distance between the CJ and the bone, 1.5 to 2. And we have about 3 millimeter between the gingival margin and the mucogingival junction, I would say. Again, looking to the CJ and the bone crest, we have about 1.5 millimeter to 2, okay? Here we have thick bone, but thin gingiva. So we send this digital wax up to the lab. It's going to mix everything with the digital workflow and define a new double digital surgical guide. Again, you can see that here the distance is 3 millimeter. And my mucogingival junction is here. Okay, not very far. But my bone is very thick. It's part of the classification of Wilson, 1990, about thin tissue, thick bone, okay? We use here the electrosurgery. I prefer to use the blade, less dangerous, I would say, for the bone. And we are cutting here because the amount of keratinized gingiva is not so important. We cut only 2.5 millimeter of gingiva. And that will be the new level of bone. This is after the cut. No blood because of the electrosurgical surgery. And now we have a nice aesthetic contour, but the bone is there. The bone is not very far. So we have to, in fact, you can see when we do the sounding, we are at the bone, 0.5 millimeter from the bone. So therefore we have to remove 2.5 of bone to find our 3 millimeter, to have the 3 millimeter from the new gingival margin defined with a guide to the bone that we are going to grind this time with the use of the surgical guide. Then we move the flap back down and we do the sutures. Optimal proportion, optimal shape, optimal shade for the teeth, for the gingiva. It will heal nicely. This is the first part. We are going to do some conclusion. Each of us has a different response to beauty, to aesthetic, to art, I would say. So you have to be aware of this beauty and aesthetic. Can we learn about aesthetic and art? I don't know. Some people are saying it's inside yourself. Some people are saying you can learn. But I give you all the information to learn by not doing mistake at all, by respecting the biology and respecting the aesthetic. The smile is one of the most important means of communication between people. Therefore, when the patient comes for a demand to restore the smile, you have to be very careful and not disappoint him. He has to be very well satisfied. This is very important. Today, as a periodontist, we can treat excess of gingiva with crown lengthening procedure, learning about knowing the classification, and we can treat also mucogingival surgery with different techniques. That could be maybe another lecture. The conclusion in French, but I'm going to translate. This crown lengthening procedure has indication for aesthetic, mechanical, and biological criteria. We have to establish a perfect diagnosis and the reason why we're doing this surgery. Is it for aesthetic reason? Is it for mechanical reason to give more tooth structure to the patient? Is it for biological reason, like the biologic width is too close from the gingival margin or for the bone? I would say from the bone. The purpose is to obtain perfect harmonious proportion for the teeth, perfect harmonious contour for the gingiva, and perfect relation between the lips, the teeth, and the gingiva to enhance the smile and maintain the result for a long time. My books, which were translated in more than 6 languages, I put 2 of them. Every master thinks like a beginner. Yes, I always read, attend lecture, attend meeting, attend webinars, and learn. I don't stop learning. As Michelangelo say, if you want to stay young, stay a student of your life. So a master thinks as a beginner, they are always learning. Now, passion. People say I work with passion. Well, I have done so many trips. I was in Portugal a year ago when we were able to travel. Still, today we don't know. This guy has written on his inside of the box of the guitar, art is the love that you put in the thing you do. Art is the love that you put in the thing you do. And I love what I do. I do it with passion. I do it with knowledge. I do it with my feeling for the beauty all the time, since I am very young. I like beauty, whatever it is, whatever it was, and it will be, I hope. So I thank you very much for your kind attention. And I know that you will have some question later during this webinar that I have recorded on purpose because of this COVID-19 confinement at home, and we don't know exactly what will happen. So I take my thing in advance to give you this present, and I hope I will have some nice feedback from you. Thank you again.
Great. Okay, thank you so much, Andre, for your beautiful presentation, step by step. As I said at the beginning, the way that you teach is something unique, and it's truly an honor for all of us to have you in this all educational platform like this one on Hot Seat. So we have some question and answer regarding your presentation. Actually, the way that you describe things left no question for me, at least, but just for going in depth of the topic, I just have some thoughts and I want to mention them with you. So first of all, usually when we want to do crown lengthening procedures, especially as dentists, not as periodontists, some dentists think that it's an easy procedure and they think that they should only just cut some part of the gingiva and that's it. Do you think that crown lengthening can be considered an easy approach, or there are very details that we need to think about them in each site and in each patient?
Well, I'm going to I will answer like my mentor, Morton Amsterdam and Walter Cohen. They used to say, there is one diagnosis and many treatments. But if you want the right treatment, you have to have the right diagnosis. Therefore, if many clinicians think it is an easy one, it is not. If you do not have the right diagnosis, you cannot establish the classification. And you were able to see in my lecture that the classification is very important. We try to simplify everything in order for the clinician to be able to know where he is or where she is in order to start the first cut. There are some biological indications which are very important to respect. If not, you can be maybe winning on some cases, saying, oh, I'm great. And other case, you don't understand why suddenly the tissue grow again, why you have deformity, why you don't have an harmonized gingival contour, or maybe some defect on thick tissue. Therefore, it is not an easy one. You have to know why you put the first cut with the blade on a certain level at the margin or at the sulcus.
Yeah.
And that has been well defined, I would say, in the lecture.
Exactly. And
any question more?
yeah, and Andre, one more thing is that when dentists do the crown lengthening, one of the questions that they might have is that in what period of time they can refer the patients for prosthetics and restorative approaches. Should they wait at least for like
this is a very,
amount of time, or they can refer the patients like in 1 week?
no, this is a very important question that have been coming on since 30 years, I would say. Everything depends on the biotype. We know that the thick biotype is healing much faster than the thin biotype. It depends also on the type of restoration that you are going to do. Is it going to be a supragingival restoration, like laminate veneer, for example, like a beautiful crown, ceramic crown, zirconia crown, being above the gingival margin, or do you have to be subgingivally oriented? So these two modalities of treatment, supra or subgingival, are going to be the guide for you with the time. However, to be more precise, I would say that for thick periodontium, I will wait about 8 to 10 weeks. And for the thin, I will wait about 12 weeks to 16 weeks.
Great. So
to be sure that the tissue are perfectly healed and I will not jeopardize the biological width by any type of restoration I will do on the tooth.
And
is it clear?
Yeah, exactly. So I really wanted to have those numbers from you because it's very important to think about the timing. Time is very important and it can guarantee the most predictable outcome that we can gain. And you talked about digital crown lengthening, digital approach, and these days, these years, actually, it's all about digital. So my next question is this: do you think that we can gain better results with digital dentistry, or the same results can be achieved if we go conventional and if we stick to the principles?
I would say that if you stick, as you said, to the biological principle, the result will be exactly the same. The only difference will be that your surgery will be faster, easier, maybe more precise, maybe, not sure. That's it. So you have to study in advance what you have found on the clinic and on the CT scan. You can also use the digital dental smile to get all your reference, I would say, before giving the cut. Then with double digital guide that the lab will deliver from the digital study that you have done, then it will be very easy to make the cut, grind the bone to the perfect level, parallel to the CJ in general, and close the flap. But still, whatever surgery we do, conventional or digital, it's still depending of the clinician working, okay?
Yeah.
And he has to keep in mind that the biological principle should be respected and clinicians are good clinician or not as good clinician, you see? The hand is still the hand which is going to give the cut even if you have a digital guide. Because if you go to the implant, we know that the precision is not zero with the digital guide. There is still some 5-degree difference when you put an implant with a guide. I have been putting implants for many years, and my implants were always parallel to each other. I never bought any angulated abutment, which means that it is a very clinician-dependent technique, whatever way you use, conventional. Therefore, for the young clinician, want to go in this procedure, it is, I repeat myself, very important to understand the different elements of the periodontal parameters and respect them. Voilà.
Exactly. Thank you so much, Andre. I think you were very
pleasure.
Very precise with the
Thank
question.
you so much. Now,
yeah, we had a little delay, and I just wanted to say thank you so much again for accepting the invitation. It was our honor to have you, and truly enjoyed your presentation. Hope you stay safe and see you very soon.
Thank you very much, my dear Omid, my dear friend. Hope we'll be seeing each other soon after this crisis, I would say. And goodbye.
Thank you.